Good evening, everybody.
Hello, Dr. Mohan. Good evening.
How are you?
Fine.
So we are having full house today.
Yeah.
Welcome, everyone. Sujay sir, welcome, sir.
Good evening, Sujay sir.
Sorry that link actually what was said. No, I did not check because I joined also through the same link,
Ah.
and supposedly we are saved on time. Thank you, sir, for joining, sir.
Good evening,
Sometimes
everyone.
googlies
Good
are
evening, sir.
required. We have to face googlies. So we are all set now, sir. Everybody is like, so Soumik will be starting. I will call him. He's here. I'll just tell. I'll be handling the quiz part. So, Amitabh ji, you are knowing the students' name, no institutions. May I request all
Yes, yes.
please name them. Some iPad 7 is there. Please name your names according to your name and your institution. For example, I know Prasuna. I have seen her personally. So, Dr. Prasuna can name herself as Dr. Prasuna Ames Kochi, or you can say Amrita Kochi, you can write. Similarly, second name not required. Kushbu can name it as Kushbu and Ames, no, sorry, Udaipur, no, RNT Udaipur. Yeah, she already named it. Yeah, so like that, each of you can name yourself so that it will be easy for Dr. Amitav to identify your institution also. Yeah, Mahin has done it. Kushbu is doing it. She's done it. So Priyanka is the presenter. Amitav knows him. So no, sir. Hi, Dr. Priyanka. Santosh Puppala is from CMC Vellore. So he has named himself like that. Varun is from PGI. Yeah, PGI is also there. So I think 5 panelists. One has backed out. There are 6 people, no? We have 7 people, no? Initially.
Dr. Mahin is there.
Fine, yeah. So I am counting. Everybody has reached, I think, no? Juveria, yeah, Juveria is also here. So I think we are all set. All across south, north, east. The east is not there. So east, you can count Raipur as central, no?
Yes.
Central. Okay. We have central institution also. Hi, Saumikda. How are you?
Hello. I was unable to join as well, so I used the passcode and the meeting ID.
Good evening, Samigda.
Good evening, Amrita. All good?
All good.
So your case is the most anticipated one.
Yes.
Passing or failing in the exam depends on it.
Everybody has diabetic foot in their examination, no? That's a very important case.
So we'll begin at 8.
Yes, yes. So 8:45, you can give it over to me now, Dr. Amitav.
Okay, sure.
I can just give some 10 questions based on your same discussion only. We'll make the quiz.
Okay.
I request the IT team to please give a cue when we are going live, okay?
So it's just to help Amrita, I begin the meeting. I hand it over to Dr. Sujoy Ghosh. He gives the introductory welcome. Then I hand it over to Amrita to conduct the case. He hands it over to Dr. Mohan, who does the quiz and concludes the program. That is how things run.
Okay. And the introduction of these people, no, the panelists, they have to introduce themselves so that
I think it's better because we are having a bigger panel every time.
So
we
6
might
people are
spell
there,
out
so
names wrongly or give the wrong
according to
statements.
their interest, they can introduce their name and institution name.
So Dr. Amritabu will ask his student panels to introduce themselves.
Yes, themselves.
Okay.
3 minutes to go live. Okay.
3 minutes to go. Can the IT team just tell us when the now 3 minutes is there. So on that 10 seconds countdown, you can give us. Yeah.
Okay, sir.
Thank you. So he has shared me the Mentee code, so I will just prepare that also. So I'll be here. I'll be waiting in the back end. Okay. Thank you. Thank you, everybody.
Please give a cue when we are good to go. So a very good evening to all of you and a warm welcome on behalf of the Endocrine Society of India. I am Dr. Soumik Goswami and I'm hosting this meeting along with Dr. Mohan Shenoy. To begin the very popular ESI case capsule, as is customary, I first invite the patron of this meeting and the president-elect of our beloved Endocrine Society of India, Professor Sujoy Ghosh, to kindly share his introductory speech with us, his welcome address with us before we move over to the academic part of the meeting. I request Professor Ghosh to kindly come up on the virtual dais.
Thank you, Shomik. Good evening, everyone. Once again, a big thank you, first of all, both to Shomik as well as Dr. Mohan Shenoy, because I think they've been doing a fantastic job in trying to continue with the ESI case capsule. Now, in the last couple of months, we've been looking at hardcore endocrinology cases. Today, we are looking at diabetic foot, particularly for the younger generation, the DM trainees, the DNB trainees. This is your rate limiting step in terms of determining whether you cross the line in your exam or not. So I think this is very important from that aspect for the trainees. And of course, in real life, if you look at the patients who get admitted in your clinical ward for the longest period of time are the ones with diabetic foot. And if you are able to do certain things, you can prevent certain, admissions. More importantly, can prevent amputations. And assessment and knowledge of diabetic foot is absolutely essential for everyone concerned dealing with patients with diabetes. So, and we have Dr. Amritavo Ghosh. I was fortunate to have worked with Amritavo during his DM tenure at our institute. And he's a wonderful guy, working very hard and doing a lot of good work in terms of research. I think he's got a multi-center grant on diabetic foot from ICMR. So we could not have found anyone better to moderate the session today. So over to the team and have a great session. Enjoy.
So thank you, Professor Ghosh. As usual, your brief but very valuable address, I think, adds value to this meeting. So we now move over to the academic part of the meeting. And as Dr. Ghosh said, we have none other than Dr. Amritavo Ghosh as our mentor today, because Dr. Ghosh is a nationally renowned expert on the treatment of diabetic foot-related problems. And as Professor Ghosh said, this is the rate-limiting step, not only for your exams, but in your practice life as well. This carries immense importance. So without further ado, I hand it over to our mentor, Dr. Amritavo Ghosh, who is an additional professor and head of the Department of Endocrinology at AIIMS Raipur. And as the main presenter, we have his student, Dr. Priyanka Panigrahi today. And of course, we have a student panel, a populous student panel, I would say, of 6 different students from different corners of our country. I hand it over to Dr. Amritavo to conduct the rest of the academic part of the meeting.
I hope I'm audible.
Yes, you are audible. Go ahead, please.
Good evening, everyone. Thank you, Somigda and Sujay sir, for the introduction. And so we will be discussing the long case usual. It is the usual long case of the exams of DM trainees. And from this diabetic foot discussion usually can go in any direction. It can range from diagnosis of diabetes to management of diabetes, the various complications of diabetes. And of course, diabetic foot is the main part, but the Viva can go in any direction. Anyways, today we will be focusing solely on diabetic foot. So I just first, before I start, I'd invite all the panelists to please introduce themselves.
Good evening, sir. I'm Dr. Cheveria Jarvis from NIMS, Hyderabad.
Good evening, sir. I'm Dr. Mahin from Osmania Medical College, Hyderabad.
Good evening, sir. I am Varun from PGH Chandigarh.
Good evening, sir. I am Dr. Khushbu from RNT Medical College, Udaipur.
Good evening, sir. I'm Dr. Santosh from CMC Vellore.
Good evening, sir. I'm Dr. Prasanna. I'm from Amrita Kochi.
Dr. Amrita, I just start. All these institutions have got a good training program, I think, and with this they also have diabetic food program also. I just wanted to find out. All of you have the diabetic food program in your next. At least you have a diabetic food salvage thing. Because Amrita has it, Chandigarh has it, AIMS, Raipur has it. Everybody has it, right? At least food surgeons.
Yes.
Yeah. Okay, over to you. Yeah.
Okay, so Priyanka, introduce yourself and start the presentation. Priyanka?
Yes, sir. Good evening to all the respectable faculties, and special thank to Dr. Amrita Ghosh sir for being a mentor for the day. I'll be starting sharing it.
Please open the PPT, then you can
Yes,
share
sir.
the screen. Okay. Yeah. Yeah, visible. Make it full screen. First slide. In the bottom half, you can see something.
Yes, sir. Mhm. Yes. Wonderful.
Perfect. Perfect. Go ahead.
The patient is a 43-year-old male coming from Baloch, Chhattisgarh, with a chief complaint of non-healing ulcer over the left foot for past 4 years, with swelling of the foot for past 2 years. Patient is a known case of diabetes for 20 years, with age of onset of around 23 years. He is also a known case of hypertension for past 2 years. Initial diagnosis was with the osmotic symptoms. 4 years back, a bike fell on the left foot, resulting in a burn injury from the silencer over the medial side of the foot, which extended over to the sole. This was associated with the formation of hematoma, which was later on drained, and post drainage, there was an ulcer which developed over the middle of the sole of the foot on the left side. But this ulcer persisted for over 2 years. And after 2 years, there was associated swelling of the foot, along with there was a ulcer formation from which discharge was seen, and a deformity which was noticed by the patient, for which he visited a different hospital. He was under treatment with debridement, regular dressing, and offloading of the foot with total contact cast was done for 3 weeks. After total contact cast, there was a gradual reduction in the size of the ulcer which was noticed by the patient. But immediately after the removal of the cast, 1 to 2 days after the removal, he again underwent a traumatic injury because of stepping on the stone. And post this, there was an ulcer which persisted till the date of presentation. This was associated with discharge, but there was no associated blackish discoloration or fever episode noted by the patient. Prior to the episode, which was 4 years back, there was no history of food deformity, swelling, or any ulcer previous history. And dressing was done at the home, and he was doing it with normal saline, and occasional use of topical iodine solution was used. And along with it, he was having a history of barefoot walking also. But currently, he is on custom-made footwear with a soft insole and a back strap. There is traumatic ulceration history on the other foot, that is the right foot, fifth toe, 4 years back, but it spontaneously recovered after 2 weeks of antibiotic therapy in around 20 days. And there was history of numbness and paresthesia also, and the main complaint of paresthesia was in the form of pins and needle, which is for past 2 years only.
So Priyanka, can we just stop here a bit?
Yes.
So I'd like to call over our panelists. So Dr. Khushbu, okay. So this patient is having long-standing diabetes and presented with a non-healing ulcer in the foot. So the duration is 4 years. So what are the causes? Why do you think this ulcer has not healed? So what hampers the wound healing in diabetes?
Yes, so the factors leading to the ulcer that can't be healed. So first is that the long-standing diabetes, maybe it is uncontrolled. Second is the presence of hypertension also, which is also uncontrolled. Third point, sir, maybe there is a history of barefoot walking, and which leads to the trauma to the foot, leading to the recurrence of ulcer or persistence of ulcer. And so fourth point is that maybe the other comorbidities associated with diabetes, like end-stage renal disease or CKD, persistence of anemia, and sir, there's also a history of foot deformities that leads to the persistence of an ulcer also, sir.
Yes, so you have pointed out most of the important points. Additionally, we should also focus on the wound care practices that have been undertaken by the patient, whether the patient is weight bearing. So that is one of the very important factors you need to take into account. So one point you said there is a poor glucose control. So can you just tell what are the how poor glucose control affects wound healing?
Sir, first of all, sir, uncontrolled hyperglycemia may be leading to the infection in the wound, recurrent infections, and also the immune response is affected also, which leads to the impaired wound healing and the precipitation of infection also. Third, that uncontrolled hyperglycemia also leads to the development of microvascular complications in a patient, like peripheral neuropathy or diabetic nephropathy, which leads to the impaired healing of the wound also. And there are certain pathways also involved in peripheral neuropathies or microvascular complications due to the uncontrolled hyperglycemia, which leads to the persistence or recurrence of ulcers.
Yes, so you have pointed out most of the important points. Also, there is a persistence of low-grade inflammation in the wound, which should also be removed. Okay, so next panelist, Dr. Prasunna. Can you tell the factors predisposing to ulcer in a patient with diabetes?
There could be any loss of protective sensation, peripheral arterial diseases, barefoot walking, trauma, foreign body, then systemic illnesses like uncontrolled diabetes and CKD, and those with the previous ulcers or previous history of amputation, deformities. All of this could predispose to non-healing diabetic foot ulcers.
Additionally, you should there will be
Calluses.
presence of ill-fitting footwear, presence of calluses, impaired joint mobility, then visual impairment, obesity, kidney disease. These things also predispose. Okay, so which is the classic triad that is known to cause a diabetic foot ulcer?
the peripheral arterial disease, loss of protective sensation.
So, how common do you come across peripheral artery disease in your routine practice in patients with diabetic foot?
It is
So, are
slightly,
most of them neuropathic or neuroischemic or ischemic?
it's mostly, most common is neuropathic, followed by peripheral arterial, ischemic, and then it could be mixed also.
Okay. So usually the classic triad that you said is presence of deformity, presence of neuropathy, and trauma, which is most commonly involved in most of the ulcers. Okay. So I can move on to the next panelist, Dr. Santosh.
Yes, sir.
So this patient is having symptoms of numbness with paresthesia. So do you think this patient has neuropathy?
Sir, yes, sir. Neuropathy is classified as large fiber and small fiber. Small fiber neuropathy is most common in diabetes, sir. It is associated with pinprick sensation, electric sensations, whereas a long fiber neuropathy is associated with paresthesias, and when the fibers are more than 50% damaged, will cause numbness, which is a negative symptom, sir. So we having the symptoms of pinprick sensation, numbness, and this, so I go with that the patient has peripheral neuropathy, sir.
So numbness, would you say it is a positive symptom or a negative symptom?
It's a negative symptom, sir. When the more than 50% of the fibers were damaged, it causes negative symptoms.
So which are the large fibers? Which are the small fibers?
Sir, A delta fibers are the large fibers, which carry proprioception and joint position.
Pardon? A
alpha, sir.
A alpha, A beta, yes.
And small fibers are type C fibers, sir.
Okay, type C and A delta.
A delta.
Okay. So motor is conveyed by?
So motor.
The types of
A
fibers.
alpha.
responsible-
A alpha.
yes.
A beta.
Yeah. And what about the deep tendon reflex? Which type of fibers are involved?
A gamma.
A gamma.
Large
where
fibers.
you form the afferent and then the motor. Okay. So from the symptoms, can you differentiate whether it is large fiber neuropathy or small fiber?
From the symptoms, if the patient has a difficulty in walking and has a rhombox positive, so it's probably involvement of large fibers, sir.
Okay.
But also proprioception. If the patient has only symptoms and clawing, so probably will have a small fiber involvements.
So which sensation is lost in some small fiber neuropathy?
So small fiber neuropathy, touch sensation is lost.
Pain and temperature.
Pain and temperature are lost in small fiber, and large fiber usually touch, vibration, joint position. Okay. And can you differentiate from the character of the pain whether it is large fiber, small fiber?
If
Burning, lancinating pain is in small fiber, sir, whereas deep-seated pain is seen in large fiber, and it's dull and deep-seated. And electric sensations is seen in a small fiber, and also allodynia might be seen.
Okay, very nice. So, Priyanka, we can move on.
Yes, sir. There is no history of postural dizziness.
One second. Can you just try to make it full screen? No, there has been some people asking me. Just put it on the side of the screen. No, you can see that one box-like thing. Okay, just click on it. It will become full screen. Okay. People are writing to us that it's not full screen. They cannot see it. Just try once, because otherwise, I think already time we have losing. That's why. If you can try, it's good. Over the top, you can see that slideshow. Just put it slideshow mode. Yeah, please do that. Sorry. From the present slide. Thank you.
There is no history of postural dizziness. There is no altered bowel habits. There is no urinary incontinence, no sense of incomplete evacuation, no erectile dysfunction, but associated with history of gustatory sweating. There is a history of bilateral sudden painless loss of vision noticed 2 years back, and there is also history of frothy urination present. Patient is a diagnosed case of CKD and is on maintenance hemodialysis.
Please stop here once more. So this patient is having history of gustatory sweating. So, Dr. Juvelia,
Yes, sir.
what does it imply?
Sir, it could indicate the involvement of the autonomic fibers, sir. So it could indicate autonomic neuropathy in this patient.
Okay, so we were discussing large fiber, small fiber. What type of fibers are responsible for autonomic neuropathy?
Autonomic neuropathies are small fibers, sir. They have
Okay,
type B and type
small
C.
fibers.
Yes.
Okay, so can autonomic neuropathy predispose to development of diabetic foot ulcers?
Yes, sir, because autonomic neuropathy can affect almost every organ system, especially in the pseudomotor. Whenever there is a pseudomotor dysfunction, it can cause dryness of the skin and fissuring, and that can predispose to entry of microorganisms and cause ulcers. And because of that, there's also the skin is dry, there's anhydrosis. All of that can predispose to formation of ulcerations.
Okay, so since we are discussing the mechanism of development of ulcer, let's just complete how neuropathy predisposes to ulcer. Okay, one of the factors you have told is
Yes, the autonomic.
autonomic. How else?
The other pathway is the motor pathway, sir. Sorry, sensory pathway. So whenever there is a motor pathway which is causing deformities, because of that there will be abnormal pressures over the foot, and because of prolonged pressure over that area, there can be formation of calluses, which can cause a hematoma and breakdown to form an abscess, infection, and ulcer.
Okay, and along with that.
Along with that, sensory neuropathy.
Yes, sensory neuropathy.
Sensory
yes.
as well.
Okay. So, Dr. Varun. So, so this patient had painless loss of vision. So,
Yes.
what are the causes of painless loss of vision in a diabetic?
So it could be because of CRAO, CRVO.
Okay.
It could be because of retinal detachment also, sir.
Okay. Yes. Proliferative diabetic retinopathy. What else can you get?
So vitreous hemorrhage can be
Vitreous
there.
hemorrhage.
Vitreous hemorrhage. Anything else? Very common.
Macular edema.
Cataracts.
Diabetic macular.
Cataract. Yes.
Painless cataract.
Okay. So this patient is having frothiness of urine. So will you suspect anything?
Sir,
And along with, of course, there is history of chronic kidney disease with maintenance hemodialysis also. So this patient is having chronic kidney disease. So, and also this patient is having diabetic foot ulcer. So would you be concerned?
yes, sir. In patients with CKD, sir, there is poor prognosis of the diabetic foot ulcer. It leads to impaired healing, and chances of amputation are also more in patients on maintenance dialysis, sir.
Okay, so how is there impaired healing?
Sir, because of
Or how and what predisposes these people to development of ulcer, and why do these ulcers heal poorly?
sir, it is because of significant atherosclerosis will also be there associated with CKD, and the immune system is also weakened.
Yes. Very good. Vascular calcification, impaired circulation, and uremia can again lead to neuropathy.
Yes, sir.
So additionally, any metabolic factors?
Sir, in CKD, anemia could also be there, which will also lead
Okay,
to
very good.
poor healing.
Okay. Hyperphosphatemia, hyperparathyroidism, hypoalbuminemia, all these can also contribute. Okay, Priyanka, let's move on.
There is no history suggestive of claudicating pain, no history of chest pain, orthopnea, or paroxysmal nocturnal dyspnea, but occasional episodes of shortness of breath is present with daily activities. History suggestive of transient ischemic attack is present 2 years back, which was in the form of weakness and loss of sensation over the right half of the face, but it spontaneously recovered after 2 to 3 hours. There is no history suggestive of pancreatitis, no history of steatorrhea, there is no history suggestive of diabetic ketoacidosis episode. History of symptomatic hypoglycemia is present with a frequency of around 15 to 20 episodes in the last 1 year, and the lowest recorded CBG value was 24.
So, can any of the panelists put input regarding presence of peripheral arterial disease in this patient?
There seems to be no evidence of PAD, sir, as per the history.
Okay, but would you still suspect?
Yes, sir. 50%
Yes,
of
sir, we can
diabetic
still,
foot
it will have
might be asymptomatic.
asymptomatic, yes.
Additionally, anything positive in history that is suggestive?
The
TIA
TIA presence could be.
Yes. So, okay. Presence of TIA, dyspnea on exertion. So, probably there is a component of coronary artery disease also. So, we should be concerned. Okay, Priyanka, let's move on.
A patient is having a family history of diabetes. Both the parents are affected with diabetes, and the approximate age of onset was around 40 years in mother and father, with the mother being obese, and no siblings are affected. There is a history of alcoholism in the patient with the intake of 60 ml of local liquor once in 2 weeks for past 20 to 25 years. And currently patient is not on abstinence, but there is a reduction in the frequency of intake of alcohol. Patient is a reformed smoker for 2 to 3 years. And with 24-hour recall method, a patient is consuming a diet of around 1800 kilocalorie per day with 20 gram of protein. A patient initially was started with an oral anti-diabetic agent, but it was uncontrolled.
So,
And
just can we go back to the previous slide?
Yes, sir.
Anything of concern here in this from this history and given this patient's background? Okay, so Dr. Khushbu.
Yes, sir. So, from the personal history, the history of alcohol and smoking is an important risk factor for the peripheral neuropathy, sir. Also,
Okay.
the history of smoking is leading to the persistence or the recurrence of ulcer. And these are the factors important in the
Anything in
personal
diet?
history. So, in diet, sir,
Protein seems to be less.
Yes. It's only 20 gram.
Protein seems to be less.
Yes.
Currently, patient is on basal bolus insulin regimen for past 11 years with intake of Lispro insulin and Glargine 6 units at night. The site of injection is in the lateral side of the thigh, and storage and techniques are adequate as per recommendation. With antihypertensive medication being consumed by the patient is cilnidipine 10 mg, metoprolol 50 mg OD, and clonidine 0.1 mg TDS. So coming to the summary, patient is a 43-year-old male with young onset diabetes and hypertension presenting with non-healing ulcer over the left side of foot for 4 years after traumatic burn injury and swelling of the foot with watery discharge and deformity for 2 years with associated paresthesia and numbness in both the feet, sudden painless loss of vision, frothy urination and gustatory sweating. History of TIA is present with no other macrovascular complication suggestive history with history of smoking and alcoholism present. So my provisional diagnosis is young onset diabetes mellitus with diabetic neuropathy, with diabetic retinopathy, with diabetic kidney disease, with non-healing ulcer on the plantar aspect of left foot, probably of neuropathic etiology with a history of TIA.
So, Dr. Prasanna, do you want to comment anything on this provisional diagnosis? Dr. Prasanna, you are there?
Sir.
So, in this patient, are you sure this is a case of diabetic neuropathy?
Yes, sir. From the history, yes, sir.
From the history, what all? Okay, so usually diabetic neuropathy is usually we should try to rule out the other causes of neuropathy. So usually it is a diagnosis after exclusion of other common causes. So what are the various common causes you would be concerned about, and which of these are present in this?
The other causes of neuropathy, sir?
Yes.
Vitamin B12 deficiency.
Okay, vitamin B12 deficiency is something you should always be concerned.
Vasculitis, rare disease like amyloidosis, Fabry's disease.
No, common diseases. Before going into the rarer ones, what are the common things you should always try to rule out?
Paraproteinemia, hypothyroidism.
Thyroid disorders, are you worried about? Hypothyroidism?
Hypothyroidism.
Okay. Yes, very good. CKD. So
CKD.
is there CKD in this patient?
Yes.
Yes.
Yes. Anything else in the history?
Alcohol consumption.
Alcohol consumption. Yes. So thyroid disorders, chronic kidney disease, alcohol consumption, B12 deficiency, vasculitis. These are the common things we should usually rule out. So can there be some indicators, clinical indicators in which if present, you will suspect other causes of neuropathy more than diabetic neuropathy? Okay, so before we go to that, which is the most common pattern of diabetic neuropathy?
Distal symmetrical.
Distal symmetrical.
Okay, so what are the other forms?
The other forms, in generalized itself, distal symmetric polyneuropathy being the most common. Others are bilateral small fiber neuropathy, autonomic neuropathy. In focal forms, it could be mononeuropathy, either truncal or cranial. Carpal, there could be an entrapment like carpal tunnel, or it could be radiculoplexopathies like hematrophy, or it could be mononeuritis multiplex.
So most common is distal sensory motor polyneuropathy. So
Yes.
what are the features if present you will suspect that probably this is not the case of diabetic neuropathy, other cause of neuropathy are present?
And it's asymmetric, motor predominant, rapidly progressive, motor fibers predominantly involved than sensory fibers, or associated systemic illnesses when it is suspected, family history.
And also if other microvascular
Proximal
complications are not associated, and there is rapid weight loss. So any type of neuropathy you are aware of associated with rapid weight loss, pain in diabetes?
Diabetic amyotrophy can have weight loss, sir.
Acute painful neuropathy, can there be treatment associated?
Associated
Yes,
neuropathy.
treatment. Yes.
So usually acute neuropathy in diabetes, what is the natural history?
It progresses.
It is self-limiting.
Self-limiting, yes. Usually, most of them they resolve over 8 to 10 months.
Yes.
So, okay, Priyanka, we'll move on to examination.
Yes, sir. General physical examination. Patient is conscious oriented, thin built, pallor is present, JVP is not elevated. There is no icterus, cyanosis, clubbing, lymphadenopathy. The height is around 167 centimeter with a weight of 63.5, making it a BMI of 22.7, waist circumference of 88, making it waist to height hip ratio is around 0.9. Coming to head-to-toe examination, there is a right eye cataract visible. On fundus examination, there is bilateral proliferative diabetic retinopathy with vitreous hemorrhage is present with areas of scar mark. Oral cavity examination, there is no dental caries, there is no gingivitis, no periodontitis. On examination, there is no goiter and there is no nodule. Acanthosis nigricans is absent for the patient. Vitals, blood pressure is 170 by 90 millimeter of mercury. So in right arm supine position, the BP is 170 over 90. With 3 minutes standing, it comes around 160 over 84. Pulse rate is around 86 beats per minute, which is regular, normal in volume and character, with no radioradial and radiofemoral delay. Respiratory rate is around 15 breaths per minute, with a body temperature of 98 degree Fahrenheit. There is a decrease in the diastolic blood pressure noticed in the left upper limb due to the presence of a fistula for the dialysis. There is no postural drop that was noticed by the patient.
So let's just next, Dr. Santosh.
So,
from general examination in a patient with diabetic foot, what are pointers in general examination will you focus on?
so we'll focus on oral examination, sir. Has any periodontitis? And next in the muscle wasting and swelling of the salivary glands suggest of autonomic neuropathy. And next is abdominal obesity and lipohypertrophy.
Okay, so more related to the condition of foot.
We look at the discoloration, loss of hair, any deformities, and any
That comes to the will come to the examination of the foot, systemic examination and vitals. So what all we have discussed so far?
So regarding to the foot, to know the peripheral arterial disease, blood pressure of ankle pressure more than 100 millimeters of mercury suggests to of good prognosis, sir. And
okay, so Dr. Mahi, can you add on?
Yes, sir. Means in vitals, pulse rate, resting tachycardia, anything we would say, sir. And here, other examination finding insulin resistant markers are not there. And BMI is 22.9. And waist hip ratio is more, sir, 0.98. And we would also see as ABI, we would see, sir, for peripheral arterial disease.
Okay,
And
also, it says you were adding something.
And postural hypotension for autonomic.
Okay, yes, autonomic neuropathy, of course, we should look for. Particularly things we should be concerned about in a patient with diabetic foot is whether there is presence of anemia, if there is pallor, and particularly the vital signs. Because if there is a presence of infection, we are particularly concerned if it is a life-threatening condition, if the infection is severe. So for severe infection, we should look at the temperature, the respiratory rate, and the pulse rate. Okay, so these are very important in this case. Okay, so Priyanka, let's move on. Just one thing, Dr. Priyanka has missed out that you have to also comment on presence of any bruit, whether renal bruit, carotid artery bruit is present. Okay, next.
On foot examination, there is no evidence of past ulceration that is visible. There is no evidence of amputation. On deformity, as you can see, there is clawing of the toe from second to fourth toe in the right side of the foot. And on the left foot, there is clawing of the toe from second to fourth toe with rocker bottom deformity and hallux
Dr.
valgus.
Priyanka, can we go back to the previous slide?
Yes, sir.
Okay, so just the previous the slide showing the footwear.
Yes, sir.
Okay, so can anybody comment on this footwear and just go to Dr. Varun?
Sir, the insole of the left foot where is torn, so it is not adequate for the person. However, the soft insole and the back strap with Velcro, that is recommended. And also, as there was ulcer there on the plantar aspect, there should be a window given for that.
Okay, so in this case, there can be scooping of the insole or outer sole. There can be a clog provided. Okay. Otherwise, this has both front strap as well as back strap, which is okay. But given that this patient is having diabetic foot ulcer, probably there could be something better for offloading the foot. Okay, so next, we can move on to the next slide.
Yes, sir. In deformity, there is clawing of the toe from second to fourth toe in the right side of the foot. And in the left side of the foot, we can see there is clawing of the toe from second to fourth toe along with rocker bottom deformity and hallux valgus deformity. There is no presence of callus that is visible, no muscle wasting that is visible, and drying of the skin is present in both the foot, and there is loss of hair also that is present in both the foot.
Dr. Juveria?
Yes, sir.
So, from this, can you comment on the findings so far? So,
Yes, sir. So, the presence of dry skin and loss of hair would indicate that this patient is having autonomic neuropathy. And in hindsight, because of his gustatory sweating, that is also adding on to this. In addition to that, because of the neuropathy, he also seems to have deformity that is contributing to abnormal pressures. And because of this, he probably had a callus leading to the infection. And also, the deformities that are seen, Rocco-Bottom deformity and hallux valgus, that can be seen when there's involvement of the metatarsal joints and the first MTP joints.
So in Rocco-Bottom deformity, what is the usual location of the ulcer?
The midfoot, sir.
He midfoot, sir.
Okay.
Midfoot.
And in Plautus?
At the tips of the fingers, sir.
DIP and PIP D.
Okay, so it can be at the
Head of the
dorsum also.
metatarsal and heads of the dorsum.
Yes, so it is usually hyperextension at the metatarsophalangeal joint and flexion at the interphalangeal joints. So there will be hyperextension of the metatarsophalangeal joint and flexion at the interphalangeal joint. So dorsum of the interphalangeal joints, that can also be predisposed to injury from inner surface of the footwear. So what is hammer toe? What is mallet toe?
So hammer toe is a flexion at the distal interphalangeal joint, sir. And mallet toe is a hyperextension at the interphalangeal, hyperextension at the phalangeal metatarsal
No,
joint.
usually mallet is the flexion at the distal interphalangeal and hammer is the proximal.
Proximal.
So in these conditions, where will you get the ulcer?
At
Tip
the
of the
Tip of the
fingers.
toes.
So,
Okay. So Dr. Khushbu, can you tell the mechanism of cloying? Any muscle particularly involved, which is leading to the cloying?
So for the clotros are intrinsic muscles of the foot mostly, sir. And
so lumbricals, yes. So
and-
what will cause the hyperextension? And what will cause the flexion at the interphalangeal joint? So it is the flexor digitorum longus and brevis, which will cause the flexion, and extensor digitorum longus, which will cause the hyperextension at the metatarsophalangeal joint. Okay, so what are the factors maintaining the arch of the foot? We can go to Dr. Khushbu.
Yes.
We have discussed.
So the factors maintaining the arch of the foot, sir, is mostly the shape of the bones, mostly the weight shape of the bones, that how the tarsal bones attach to each other and interlock each other, and especially the talus bone among these tarsal bones. Then other than that, sir, bones, the ligaments, which is important for maintaining the arch, and in that the plantar fascial ligaments and also the other spring ligaments. And after that, sir, the certain muscles are also very important maintaining the arch, like tibialis posterior and the peroneus longus. And also, sir, so these are the factors that maintain the
So
arch.
this will act as a sling.
Sling, sir.
Okay. So which will pull the arch up.
Yes.
Okay. Okay. And Dr. Priyanka, we can move on.
There is no visible erythema in both the foot. The nails are long and improperly cut in both the foot. The web spaces are free of any fungal infection. There is no intertrigo. The arch of foot is maintained in the right side of the foot, but there is a loss of the both medial and lateral arches in the left of the foot. There is a visible ulcer present in the left foot of around 3.2 into 3 centimeter in the midfoot region, which we will be discussing in the subsequent slide. Coming to the ulcer examination proper.
Okay. So I'll just interrupt here, Dr. Priyanka. So when we evaluate a patient with diabetic foot ulcer, we should always go slowly before we start with the examination of the ulcer. First, we look at the systemic features. Then we look at the condition of the footwear. Then we look at the condition of the foot. and then ultimately we move on to examination of the ulcer. Okay, Dr. Priyanka.
Yes, sir. On inspection of the left side of foot, there is a midfoot ulcer that we can see on the left side with a size of around 3.2 into 3 centimeter. There is overhanging edges that is present with indurated margin, and there is visible yellowish discharge from the site of ulcer, but no gangrene is seen. On palpation, there is local raise of temperature that was felt, and the tenderness was elicited below the left ankle joint. The floor is formed by pale granulation tissue, and the base is by the muscle and the tendons, with the depth of ulcer being 2.5 centimeter. But the probe to bone test was negative for the ulcer.
Okay, so Dr. Prasanna, so from this examination, so can you tell the type of ulcer, whether it is neuropathic ulcer or a vascular ulcer?
Looks like a neuropathic ulcer, sir. There are no
Okay.
signs because of the location and no evidence of ischemia and
So-
along with charcoal.
Okay, so for ischemic ulcer, what is the usual location?
It will be located at the tip of fingers. There could be absent pulses. There could be gangrene.
Okay, and it can be pain.
Pain.
Yes. So, is there sign of infection? So, what are the various signs of infection?
Purulent discharge, pale granulation tissue, surrounding erythema more than 2 centimeters, depth of the ulcer, and then systemic features of tachycardia, hypoxia, tachypnea.
Okay, those are features of severe infection. So, just say what are the primary signs of infection? So, one is you have told that there is purulent discharge and erythema. Anything else? So, usual features of inflammation: tumor, rubor, calor, dolor, all those. Okay. So, what are the secondary signs? You have already enumerated a couple of them.
Signs of sepsis, tachypnea, tachycardia, hypotension.
No. So again, those are systemic features, severe infection. Usually, as in this patient, there is some secondary signs of infection that we can see. One of them is undermined edges. Then pale granulation tissue, presence of serous discharge, presence of foul smell. So among these, this patient has presence of some discharge. Patient has undermined edges. So undermined edges. Can you think of any other differential diagnosis?
Common cell carcinoma.
Okay. Pyoderma, gangrenosum. So we'll move on to next.
On palpation, there was increase in the warmth of the left side of the foot, and the pulses were palpable in both the foot in the below the ankle joint. Now coming to the neurological examination,
And Dr. Priyanka, can you just move on to move back 2 slides?
yes, sir.
Just the previous slide.
Yes, sir.
Yes. Okay. So, Dr. Santosh,
So,
probe to bone test is negative in this case. So, what is your understanding from that?
so probe to bone test is usually done to know whether there is existing osteomyelitis or not. Because in probe to bone test, when we do it, when we hit a hard structure, it indicates we touch the bone. But in this case, though the probe to bone test was negative, because of the existing ulcer is more than 30 days, so I still go with there is an osteomyelitis. So probe to bone test doesn't say negative, doesn't say that there is no osteomyelitis. There is chance of still having osteomyelitis in this case.
Okay, very good. So, can you tell the sensitivity specificity of the probe to bone test?
Sir, it's around 60% and 80%.
Yeah, it's more than 80%. Even specificity is more than 80%. Okay, we'll move.
Coming to the neurological examination, the bulk and tone were normal. Power was normal around all the joints in the upper limb. Hip flexion is 4/5 in both the left and right side. Hip abduction and adduction is 4/5 in both the sides.
So I think it's already 8:50. So can I just summarize the findings of neurological examination?
Yes, sir. Only there was 3/5 power in the first first MTP joint flexion. Along with that, there was impaired DTR in the ankle joint in both the sides. There was loss of sensory in the form of crude touch, fine touch, and pain and temperature in the lower limb below the ankle joint in the left side, but it was graded loss that was present. And 10-gram monofilament was out of the 6 sites, only 2 sites could be perceived by the patient, and out of the 5 sites in the left side, only 3 sites could be perceived. Vibration perception was impaired on both the right and left side of the foot.
Okay. So from this, what is the type of neuropathy, Dr. Mahi?
It is both small fiber and large fiber, sir. Mixed DSP and
So there is motor involvement as well as sensory involvement. So what is
sensory.
loss of protective sensation?
It's elicited by 10-gram monofilament, sir, where actually by IWGDF 3 sites have to be seen. If 2 sites are absent out of 3, then it is said as loss of protective sensation, and it can and also vibration perception can also be done along with that if it's impaired.
Okay, so loss of protective sensation usually indicates the degree of neuropathy where the foot will be at risk of complications. So it does not necessarily rule out early neuropathy. So usually it is a 10-gram monofilament, as we have told, along with one of the others like vibration sensation or vibration perception threshold or pinprick sensation or deep tendon reflexes. So usually you will have to at least one abnormal test of these will give you the diagnosis of loss of protective sensation. Or if you have done 2 tests, both of them should be normal to say that this patient does not have loss of protective sensation. Okay, so suppose we don't have these equipment in a busy OPD, we don't have all these instruments. Can you still use your...
Yes, sir.
Okay, yes.
If which touch test we can do, sir, in
where
monofilament is not.
Okay. So, Dr. Juvelia.
Yes, sir.
Okay. So, is it sufficient based on this feature that this patient has neuropathy, or do you want to do a nerve conduction study?
We've evaluated all the small fiber, large fiber, and the reflexes as well, sir.
Yes. So, yes, more or less we are sure. Nerve conduction study is usually not necessary in patients. So, if you do, what type of neuropathy will it usually detect? Large fiber or small fiber?
Generally, so it tells us about the type of the neuropathy, either demyelinating or axonal. So it tells us about the small fibers, and if there is a decrease in...
Usually it is large fiber that nerve conduction study. So any tests, or any of the panelists, any of the tests you are aware of which detects small fiber neuropathy?
CCF and pseudomotor scan.
Okay, pseudomotor, very good.
And corneal confocal microscopy.
Very good. Okay, Dr. Pinker will move on.
On cranial nerve examination, he was having loss of perception of the red color. Other than that, other cranial nerve examination was normal. And the vascular...
Cranial nerve, what are we looking for? Any of the panelists? Common cranial nerve that may be involved in diabetes?
Mostly third, sir, with pupillary sparing.
Okay.
3, 4, 6, and 7.
Maybe third. Okay. Okay, let's move on.
Vascular examination was normal for the patient with all the pulses were palpable. And other system examination
Okay,
was
so
normal.
and just go back to the previous slide. Antebrachial index. Dr. Vadu, what is antebrachial index?
Sir, it is used to assess peripheral vascular disease. We measured the systolic pressure at the DPA as well as posterior tibial artery on both the sides, as well as the higher of the systolic pressure in the brachial arteries is used, sir. So the lower pressure among the lower arteries divided by the highest pressure among any of the upper arms gives us the ABI. Normally it is between 0.9 to 1.3, sir.
So, what if it is more than 1.3? So, what does it suggest?
Suggestive of calcification, sir.
Okay. So, can a patient have calcification but peripheral arterial disease with a
Yes.
raised ABI but presence of peripheral
Yes,
arterial disease? In
it
that
does
case,
not.
what test can you do to?
So we can check TBI or toe pressure can be checked in that case.
Okay. So, how do you interpret toe pressure?
So toe pressure normal is more than 55 to 60, sir. If it is less than that,
Yeah, usually we take as less than 70 as the normal.
110 is normal, sir. And less than 70.
No, we are talking about toe pressure. Less than 70. Yes.
Less than 70. 70 to 50, less than that.
Yes. So, okay. Dr. Priyanka.
Examination of other systems, the respiratory and cardiovascular system were normal. Gastrointestinal system was also normal. There was no hepatomegaly or there is no palpable mass. Coming to the summary, it is a 43-year-old smoker and alcoholic male with young onset diabetes and hypertension with non-healing ulcer on the left foot with swelling and discharge. On history and examination, there was a 3.2 into 3 centimeter ulcer over the midfoot of the left side with signs of infection and with rocker bottom deformity of the left foot, absent bilateral ankle jerk, impaired vibration perception, pain, touch and temperature were lost below the ankle bilaterally. And there was with suggestive history of no suggestive history of peripheral artery disease, but on examination there was suggestive history of diabetic sensorimotor neuropathy along with retinopathy was found.
Okay. Dr. Vadu. So, in this patient, is there any feature of limb-threatening diabetic foot?
no, sir. There was
Okay.
no
What are
issue.
the usual features?
Sir, any rest pain or ABI also less than 0.4 or 0.5 is taken, and TBI less than 0.3.
Okay. Critical limb ischemia then?
And any gangrene, any gangrenous changes.
Okay. Very good. Then presence of necrotizing fasciitis or presence of osteomyelitis or deep-seated abscess. These are also features of limb-threatening disease, which should be looked into for urgent intervention. Okay. So how? Okay. And just Dr. Khushbu, how will you evaluate this case?
Sir, as the patient is diabetic or present with the also present with the diabetic foot and with the rocker bottom deformity, maybe there's a charcot foot also of the left foot. So first of all, sir, with the routine blood investigation, sir, and in which there is a CBC, LFT, RFT, and along with that for the sugar, fasting blood glucose, postprandial blood glucose or HbA1c, and after that, sir, for the foot, especially the sir X-rays of the foot, and the X-ray we prefer generally the dorsoplantar view and the lateral standing view or the anterior lateral oblique views, and for the assessment of the foot. And sir, as the sir ulcer is so these are the mainly investigations, sir.
Okay. So do you want to do a culture in this case?
Yes, sir.
Do you want to do a culture in this case?
So with signs of infection in the purulent discharge and the other infective signs present in the ulcer, so maybe the culture is also important before
Okay, very
starting the
rightly pointed
antibiotics.
out that culture should be done only if clinical signs of infection are present. If there is no clinical signs of infection, no need to do a culture. Okay. So in this case, there are some secondary signs of infection, so a culture can be considered. Okay. So in an X-ray, what will you look for? Dr. Prasun.
We look for changes of Charcot food. That is in stage 0, that is prodromal stage, there will be no changes in the X-ray. In stage 1, which is the formative stage, we'll find subluxation, osteopenia, and dislocation. In stage 2, which is coalescent stage, we'll find sclerosis, absorption of the debris, and bone breaks. And in the reconstruction phase, we find deformities like fixed joints and rocker bottom abnormality and fibrotic changes.
Okay, so they may be there. Okay, and apart from the Charcot changes, anything else you are particularly concerned about?
Foreign body.
Okay, very good. Anything else?
Osteomyelitis.
Chronic osteomyelitis.
Yes, features suggestive of osteomyelitis. So, Dr. Santosh, what are the features which may be indicative of osteomyelitis, and how sensitive is X-ray for detection of osteomyelitis?
The changes in X-ray that suggest of chronic osteomyelitis are loss of continuity in the cortex, periosteal reaction, osteopenia, and at site of sometimes connection site with the sinus, with the underlying bones.
Okay, so how sensitive it is for detection of an osteomyelitis?
So early osteomyelitis we are unable to detect from the X-ray, but if the ulcer is like a chronic osteomyelitis more than 6 weeks, it is around 80 to 90%.
Usually sensitivity is around 55%. So sensitivity is low, specificity is more around 70%. However, sensitivity can be improved if we repeat the X-ray after an interval. So repeat X-ray is very important when we are suspecting, but X-ray has come out normal. Okay, and okay, so suppose X-ray is negative, and in this case, okay, Priyanka, can you show us the X-ray?
Yes, sir. Yes.
Okay, Dr. Mahi, comment on this X-ray.
Yes, sir. There is soft tissue swelling, sir, on the plantar aspect because of the deformity, and there is sinus tract ulcer is there, and the joints in the midfoot there is tarsometatarsal joints. There is fracture seen, and the joints are narrowing of the joints is seen, sir, and.
Okay, so anything regarding the arch?
Arch, there is rocker bottom, there is plantigrade feet, sir.
So okay, based on this X-ray, can you classify this Charcot?
This is Lisfranc joint is affected, sir. Sanders and Freiberg classification, class 2.
Yes.
And
also
the subtalar.
The tarsal bones are also involved, so we can also say it is class 3 also.
3.
Yes. So, and some lines have been drawn. Can you?
Yes, Mayer's angle. Mayer's angle, sir. It is showing that there is an angle formed. Usually, it is 0 degrees Mayer's angle, but here it might be some acute angle is there. More than 15 degrees is abnormal.
Okay, so it is the line drawn between the axis of the metatarsal and the axis of the
first metatarsal, first talus and metatarsal.
talus and metatarsal. Okay. So
and
just
even
one more line.
Cuboidal height is also
Calcaneal
there. Calcaneal
pitch.
pitch and also cuboidal height is also there. Sir.
Okay.
The cuboidal height is decreased and calcaneal pitch is also
So usually less than 17 degrees
less
is
17
considered.
degrees. Usually 20 to 30, but here.
Okay. Yes. So
Dr.
from
Shamita,
this-
can we close? I think we are
okay,
almost-
sure. So
No,
because
yeah, you can just
diabetic
you can,
foot
any more slides are there,
discussion
any more
can
slides are there.
prolong to any length.
Yeah,
We'll stop it now.
very long. So any more slides are there? You can just run those slides because you have presented, you have prepared so much.
Dr. Priyanka, can you just tell the summary slide and the diagnosis?
Yes, sir. A 43-year-old smoker and alcoholic male with young onset diabetes and hypertension with non-healing ulcer of the left foot with swelling and discharge, with a suggestive history of diabetic neuropathy, retinopathy, and diabetic kidney disease, with left foot diabetic foot ulcer, with moderate infection as per IDSA, with of neuropathic etiology, with active Charcot's neuroosteopathy in the stage of coalescence. So my diagnosis will be young onset diabetes with hypertension, with distal symmetrical peripheral sensorimotor polyneuropathy, with diabetic kidney disease, with proliferative diabetic retinopathy, with left foot neuropathic diabetic foot ulcer, with moderate infection, with active Charcot's neuroosteopathy, with transient ischemic attack, no PAD and CAD, with uncontrolled glycemic values.
Okay, so anyway, the discussion will continue. But Amitav, what do you want students to benefit like maximum? No, how much time should they spend in the long case? Because there is also a question. Diabetic foot will take a long time. No, so how do you want? Because an exam situation, no, we will have very limited time for a case. So what do you suggest for a student? Because that will be the most important thing as a tip from students, from your students.
Yes, so usually what I would suggest the students is incorporate diabetic foot examination in your routine practice, so that in examination you can do it very quickly. So the more you practice, the more fluent you become with the nitty-gritties of the examination. Of course, it is a history of diabetes, the diet, everything is so long, you get, and you have very limited time. So you should always keep in mind that while examination of the diabetic foot, we should always start with the vitals, and don't forget the footwear, look at the condition of the limb, and then only examine the wound, and subsequently, not to forget the neurological examination and the peripheral pulses and ABI. So these are the minimum things that you need to do, and you should always try to do 2 to 3 minute foot examination of all the diabetes patients you are doing, so that you don't miss out on the things. Also, you should look between the toes, the inspection, the deformities, all these things you should
yes.
commonly look into.
It's a practice we should do daily.
Yes. So that is the only thing how
I
we
remember
manage time
I
in
had
exams.
got a case of a type 1 diabetes patient with long-standing ulcer and she had a Charcot also. So their discussion went for long time. So I think type 1 diabetes also was there. Klinefelter also was another person got Klinefelter with diabetes food. So like so many endocrine conditions can come together with the diabetes food. And I think very kudos to you. You did very well. So I will just begin the quiz once your slides are done. Thank you, Abhitav Ghosh, and thank you, Priyanka. So I am the quiz master, so I will also learn more from.
So before I end, I'd just like to thank Dr. Mohan for inviting me and anchoring this together for past few days so nicely.
Thank you, and you did very well, Dr. Amitav. Thank you. So can we end it so that we can go to the business end? So it is the most important that all students will enjoy. I think we have got a good number who are already waiting in the waiting room. So you can just take 1 minute and I'll just start the slide. Those who are sitting there, you can just sit 1 minute. I'll just start the slides. Yeah. Okay, I'm just ready. Bashir bhai, you're also there?
Yes, sir. Yes, sir.
Okay, so we are going to have a very quick quiz. I've kept 2 files so that I will not reveal the answers early. So thank you once again. Welcome everyone. Thank you for joining today's episode of ESI Case Capsule. If you have joined just now, you have missed a great interaction discussion. But if you have joined from the start, you will definitely benefit from the diabetes food quiz also. So there is no disclosures. We are all enjoying the academics here. So before we start, I would like you to just log in via this QR code. This QR code will be displayed for 1 minute. So there are 10 MCQs. We are going to go to the Menti platform via this QR code. Please remember that only those who put their name and institution will get the prizes, because whoever is 1, 2, 3, if you have put some odd names, username has to be changed to your institution and your original name. Because we have institutions, we are difficult to chase the person who has won, and some people come and ask us, I have won, I don't know whether price is not coming. So please do that early only. You have to select the single best answer from the 4 options I'm giving you. There is a time limit which will be there in the display. So I hope you're scanning the QR code. Once you have won it and you are knowing that you are ready, then you can also send it to us, your institutions and your name and the winner details. We will get back to you for the prize details. So post this, we'll have the discussions of the answers also. So we have 3 winners at the end of the quiz. We'll try to stick on to our time limit, and we will give you explanation. So Bashir bhai, let me know how many people are joined now, right now.
34.
34. Okay. So we'll keep at least for 30 more seconds, because we have just consumed some time. So we need to put a time. We have to finish everything by 9:30 at least. Okay. So let me know if the numbers are increasing. The student panelists are also welcome to join the quiz program. And those I think who are at home listening to the quiz, you can also listen to enjoy the answers also at the end of this. It will be basic questions only. I have tried to stick on to the what Amitav Ghosh and the DNB curriculum is giving us. Has the number increased, Bashir bhai?
Yes, sir. Can I start with the test question?
Yeah, you can start with the demo part. Yeah, we have one demo question. Demo question done?
Done, sir.
Okay. So your seat belts ready. You are going to start. Good luck. So the first question is there on your screen. It's a case scenario. 45-year-old male with long-standing diabetes presents with a plantar ulcer beneath the first metatarsal head. The ulcer extends through the subcutaneous tissue and exposes the flexor tendon. There is mild surrounding cellulitis, no abscess, osteomyelitis, or gangrene. Pedal pulses are palpable. So according to the Wagner-Megid classification, which was discussed earlier, what is the most appropriate grade of this ulcer? Options are A, B, C, and D. A is grade 1, B is grade 2, C is grade 3, and D is grade 4. Time already started once the question came in. So we'll just see how many people are answering. It's a straight question. So maybe we can give 20 seconds only.
Next.
Okay. The next question is coming there. 60-year-old woman with long-standing type 2 diabetes with plantar ulcer, purulent discharge, dry gangrene of second row. Examination reveals loss of protective sensation, absent pedal pulses, and an ABI of 0.55. The multidisciplinary team visits and examines and estimates the limb loss and wants to determine the urgency of the intervention. There is one classification system which will help us in guiding the prognosis and management in this particular case. What is it? Options A, Wagner classification, option B, Petty's classification, option C, Sinbad classification, or option D, Wi-Fi classification. Again, it's a straight question, 20 seconds only.
Next, sir.
Thank you. Question number 3 is on your screen. 58-year-old male with type 2 diabetes present with 2 centimeter superficial ulcer with 2 centimeter or less of erythema and mild tenderness. There are no systemic features of infection, no previous history of MRSA colonization, and has not received antibiotics for the last 6 months. So it's a fresh infection which is coming up. And which is the most appropriate empirical of oral antibiotic antimicrobial strategy? Options A, cephalexin or amoxiclav. Option B, doxycycline plus ciprofloxacin. Option C, ciprofloxacin monotherapy. Or option D, no empiric therapy till culture results are available. All these are my own patients who have visited me in the last 6 months.
Next.
Thank you. So leaderboard will be shown at the end of 5th question, Bashir Bhai.
Yes,
Question number 4. Question number 4. Which ABI value is most significant or indicative of significant peripheral artery disease, impeding the wound healing? Options A, 1.1. Option B, 0.95. Option C, 0.6. Or option D, 1.4. Internationally accepted index or ABI value, which will indicate the significant PAD impeding the wound healing. Very straight question only, so I think you will answer it correctly only.
Next.
Thank you. So 5th question, after this leaderboard will be shown. A 58-year-old man with long-standing diabetes, advanced CKD and chronic plantar ulcer undergoes vascular assessment. His ABPI or ABI is 1.4. What will be the most appropriate interpretation of this ABI of 1.4? Option A, it indicates non-compressible arteries and warrants for assessment. Option B, ABI excludes hemodynamic significant PAD, so you can reassurance. Option C indicates preserved arterial perfusion and low risk of amputation. Option D reflects increased peripheral artery disease and diagnostic of medial arterial disease. So you can answer, take your time.
Sir, can I show you the leaderboard?
Yeah. So we'll stop share screening. So how was the quiz? So we'll start the leaderboard. We'll see how many people participated actively. Okay. Very good numbers here. And I think numbers are coming up. I think more than 40 have participated, I think. Yeah. So the leaderboard is dynamic. It will keep on changing. So up till now, Khushbu is leading. Santosh is second. Mahin is third. I think those who have participated actively will definitely benefit, though not directly, but indirectly as well. So thank you. So we'll go on. So we'll go back to the screen sharing. So I was at question number 5. So I'll go to the next question. Screen is visible, Bashir?
Yes, sir. Yes.
Visible, no? Visible. Okay, thank you. So question number 6 is front of you. There was a discussion point by Dr. Amitav Ghosh where he asked a question. Which of the following is considered a negative sensory symptom than a positive in diabetic peripheral neuropathy? Option A, B, C, and D. Option A, electric shock-like sensation. Option B, pain evoked by light touch. Option C, reduced perception of temperature. Option D, pins and needle sensation. It's a basic medicine thing, but still, when you go towards the hardcore endocrinology, we may have doubts about this. So negative sensory symptom. among these four options?
Next.
Thank you. So question number 7, again a clinical situation. 56-year-old male with long-standing diabetes, established peripheral neuropathy with a unilateral warm erythematous swollen foot of 2 weeks duration. He is afebrile and reports minimal pain. X-ray is unremarkable. What would you do appropriately for this patient? Option A, would you start an empirical antimicrobial therapy with protected weight bearing and pending the further imaging? Option B, would you do an urgent immobilization, complete offloading while arranging a confirmatory imaging? Option C, do you go for a MRI followed by treatment if bone marrow edema is demonstrated in that? Option D, surgical stabilization because early intervention prevents a deformity. So which among the four would you consider as most appropriate immediate management?
Next.
Thank you. So question number 8, which component of diabetic neuropathy is most closely associated with the initiation of plantar ulceration? Option A, autonomic neuropathy causing AV shunting. Option B, large fiber dysfunction causing loss of protective sensation. Option C, small fiber neuropathy causing neuropathic pain. Option D, proximal neuropathy causing muscle weakness. So you can see the options A, B, C, and D. Which among these four are most closely associated with initiation of plantar ulceration? I have taken from a guideline by International Action Task Force.
Next.
Okay. So question number 9. 43-year-old male with a long-standing diabetes, end-stage renal disease, Charcot deformity, extensive midfoot, hindfoot osteomyelitis, undergoes multidisciplinary evaluation. The limb is deemed non-salvageable and major amputation is being considered. Which among these four things, options given here, with this factor will determine primarily the level of amputation? So I know that you are all endocrinologists, but definitely we are the team of podiatrists also. So option A, extent of neuropathy and duration of diabetes. Option B, proximal infection and the surgeon preference. Option C, likelihood of obtaining a durable, well-perfused and functional stump. Option D, patient's age and expected life expectancy. So this is a very, what you call that, very emotional situation also. When the person undergoes amputation, what would you do? Clinically, do you go by the guidelines? Which was the factor which primarily determines the amputation?
Next.
Last question. Male engineer with recurrent neuropathic plantar ulceration asked me about new technology which may help him with a further ulcer episode. What would I have told the patient injury and reduction in the ulcer? Would I go for continuous glucose monitoring integrated with remote monitoring? Would I be comfortable with the home foot temperature monitoring using sensor-enabled footwear and smart insoles? Would I go for telemedicine-based foot surveillance with clear photographic assessment? Or would you like to ask the patient, because he's a computer engineer, would you go for artificial intelligence assisted imaging for annual foot risk classification? These are the four options. What do you think is guideline established and recently published by Podiatric Society of USA for the long-term reduction, at least at the next 1 year basis at least?
Done, sir.
Okay, so I hope the answers will also be interesting. So shall I go for the answers now and leaderboard at the end, Bashir bhai?
Sir, as your wish, sir. Now also it is ready.
Okay, I think now we can do for the questions answer. Okay, I will stop sharing. You can reveal the questions. I have opened other system. I put another file only. So I went out. So displayed already.
No, sir. Doing, sir.
लेकिन यार ये गाड़ी तो पक्का मेरा दोस्त ही लेके आया होगा, लेकिन यहाँ पे तो मेरा दोस्त दिखाई भी नहीं दे रहा।
Shall I do my answers then? Okay, it's coming. It's coming. Yeah. Okay, so we have the leaderboard establishing now. A very close competition between Muskan and Khushbu Garg. So let us see who has won finally. Okay, the winner board shows Khushbu Garg from Udaipur. Congratulations. Dr. Push, that is another person by name PLD. Again, username is wrong. So I'm sorry. I think we are unable to identify you. Second prize to Muskan RNT. So I think RNT has taken 1 and 2. And PLD, we don't know. But the fourth question goes to Raj Kamal, is it? From Jipmer. So if in case we are not able to identify this PLD, the fourth prize winner will get the third prize. Okay. So thank you. So I think the questions are very important for the answers also. So let me see how we can listen to the answers also. So I'm just trying to upload the answer key and this thing. Is my screen visible, Bashir bhai?
Yes, sir. Yes, sir.
Okay, so let me go for the quiz answers. The first question, the classification, the answer is option B, which is the Wagner stage grade 2, not stage, grade 2. You can see the classification very clearly shows you the depth. So beyond, you can see that the option 3, grade 3 is abscess or bone. Option 4 means gangrene, and option 1 means superficial only. Okay. That is the first question. Second question was this one regarding the urgency of vascular intervention. So this is called Wi-Fi classification. So we are hearing it more often nowadays, used extensively by podiatric and vascular surgeons. So it calculates the wound, ischemia, and foot infection. So I hope you will also learn this in the upcoming years, and maybe you are asked in the Viva also about this classification. Option 3, the question 3 was regarding this case of superficial, and you can see the oral antibiotic strategy. Actually, we'll go for the basic only, the baseline, that is the cephalexin or amoxiclav, which is the rational one for mild DFI. This is as per the established guideline. We also go for only the good infection. We should go for the best infection. So we have to classify according to the flora. Cephalexin will target the common infections. You can know that. We'll also get a wider range of spectrum. ABI, you all know this answer. It is option C, which is 0.6, severe ischemia, critical limb ischemia. This graphic shows you what is important. Critical ischemia is less than the 0.6 effect itself. You can see 0.5 or below, it is critical. Mild to moderate is 0.7 to 0.9, more than 1.3, non-compressible. So continuing with this, the question 5 had a 1.4. In that, it is falsely elevated. So that is why you should also know that the calcified or non-compressible arteries, so that indicates by this, so warrants the further perfusion. That is the option A is the right answer. So question number 6, again, what is the negative sensory symptom? So answer is option C, that is reduced temperature perception or thermesthesia. So again, electric shock and pins and needles are coming as positive, whereas negative is the allodynia and thermesthesia. Question number 7, warm feet. It is definitely a case of immobilization required, Charcot, acute Charcot, and you definitely have to go for the immediate management by giving your treatment with immobilization, and if you can give a cast offloading, it's good. Option of question 8 regarding plantar ulceration, most closely, the option B is the right answer. That is large fiber dysfunction. Established guidelines have shown that LOPS with large fiber dysfunction indicates that it is a long-standing and direct impact leading to mechanical or plantar ulceration. Question number 9, emotional aspect. How was the level of amputation decided? It is by understanding the functional potential, the vascular perfusion, and the stump duration and the stump durability. So option C fits the, and that is a durable, well-perfused functional stump is what we want, because later on the patient mobility also is the major deciding issue. The last question, 48-year-old male computer engineer with recurrent ulcer. What is the hypothesized as the strongest evidence? The option number B, home food temperature monitoring, sensor-enabled footwear is the ideal situation. This is established as the one which may definitely help us to prevent the foot ulcer and foot amputation. So question answers, I have given as answer key. You want to revisit the answers, please do so. So timely intervention in diabetic foot care significantly reduces the major amputation rates. That is why today's discussion is very significant. Successful diabetic foot management requires multidisciplinary approach. So assess the wound or classify it, treat it accordingly, appropriately, protect the issues. That is the long-term aspect. So that is the point which I also have learned through my last several episodes which I have learned here. So I think that concludes the episode. Is Dr. Saumik, Dr. Saumik here? So if he is not there, it's my privilege to give you the vote of thanks. So it's my great opportunity here. I'm very happy that today we had a very good discussion from Endocrine Society of India's Executive Committee. Was very grateful to give this opportunity. President Dr. Kaushik Pandit, Secretary KVS Harikumar sir, our President-elect Dr. Sujay Ghosh sir, my co-coordinator, Dr. Saumik Goswami. I thank all of you. I thank the team video for establishing the wonderful technical help. I also thank all the institutions, especially I thank Dr. Amitava Ghosh from AIIMS Raipur, who has given his dedicated time to discuss and teach us. From his student, Dr. Priyanka Panigrahi did a very good presentation. I am also grateful to all the institutions, PGI Chandigarh, who had sent his student, Dr. Ashu sir has sent his student, Varun, Dr. Kansara sir sent his student, Kushbu. All the faculty had sent their students from CMC Vellore, Dr. Nitin Kapoor sent his student, Upala Santosh. Mahin was sent by the Osmania team, Rakesh Sai sir. I also thank Dr. Harish Kumar, who is my teacher and mentor from Amrita Institute, who had sent his student Prasuna. I am also thankful to NIMS Hyderabad, Dr. Beatrice Ann, who had sent her student Mahin. And I think we had a very good discussion. It was very well accepted. And Joveria was also there from NIMS Hyderabad. So I also thank everyone who have joined today. I hope we have tried to match your expectations. If you want to learn more topics, please write to us. We'll include more interesting discussions in the next episode. So the last week of July, we'll have a discussion which will be basically on another topic of examination importance, so long case. So if I have forgotten anybody in thanking, I am sorry. So I thank you all for joining today's episode, all delegates and all the senior people who have joined here. I thank the team Lupin for academic support also. I thank you for joining today. Jai Hind, Namaste. I look forward to the next episode. Good night.